Okay, welcome back. We are delighted to start our next section. Our first speaker is Dr. Thor Sundt, who's the Professor and Chief of Cardiac Surgery at Mass General Hospital. He serves as the Director of the Heart and Vascular Institute at Mass General Hospital as well. Dr. Sundt is a talk I'm especially looking forward to because he's been an international thought leader on thoracic aortic aneurysms and disease and how the leftward shift of treating patients with aortopathy has occurred over the last several years. So look forward to hearing Dr. Sundt and some questions. Unfortunately, he couldn't be here with us today because of a personal emergency, but he's been generous enough to record his talk for us. Thank you.
Thank you for giving me the opportunity to chat with you today about a topic that I've had interest in my whole clinical career. Indications for intervention on the ascending aorta, the aneurysmal ascending aorta. I'm going to focus specifically on indications in the setting of a bicuspid aortic valve. The controversy is greatest here. I think that the clinical implications are most impactful here. And the discussion is really pretty similar around a trileaflet valve, but I'm going to focus specifically on bicuspid valve, which is where my greatest passion about the subject, frankly, lies. This is, I have no financial conflicts to declare. This topic is a hardy perennial. It turns up all the time, over and over. It's got me a lot of fancy trips to a lot of fancy places. In part, I think, because I present a controversial perspective, which I think is why I've been invited to chat with you here today. The interest in bicuspid aortic valve associated ascending aortic aneurysm has grown over time. The interest in bicuspid aortic valve has increased over time, and much of that controversy, most of those publications are with regard to the management of the ascending aorta in this setting. And you can see over the course of from 2000 to 2022, a tenfold increase in the number of references in PubMed surrounding a bicuspid aortic valve and aneurysmal dilatation. As I said, my interest has gone back many years. In the year 2000, I wrote this paper, was my first paper about bicuspid aortic valve associated ascending aortic aneurysm. Note for later in our discussion that my threshold has changed. Back then I was intervening as low as 4 centimeters, not as low now as then. What are we trying to prevent? Why are people excited about this topic? Well, we're trying to prevent aortic dissection. Aortic dissection is the most common aortic catastrophe. It's a terrible, terrible disease. 25% of patients that make it to the hospital die. That's broadly speaking, perhaps not at every institution in every setting, but broadly speaking, a quarter of patients who make it to the hospital die. 30% of them, at least, if not 2/3 of them, require a subsequent operation on the aortic arch of the descending thoracic aorta, and there has been relatively little improvement in that in time. Even more concerning, perhaps, are these data from the UK that show that the acute dissection mortality rate before people make it to the hospital is as high as 50%. So this is a lethal condition and certainly one we want to prevent. Now, we've long known that there's an association between thoracic aortic size, thoracic aortic diameter, and the risk of death. This is a study from 1964. Now, it's not an autopsy study. We can't say exactly why all of these people died, but I can imagine easily that a significant number of them died from rupture or dissection of their thoracic aorta. Interestingly, in this study, John Joyce identified 6 centimeters as a critical threshold, and subsequently, the Yale database, they've got a large thoracic aortic database at Yale that has done a lot for us to understand the natural history of disease, has indicated, once again, that 6 centimeters is the hinge point, if you will, for aortic complications. Now, bicuspid aortic valve has been recognized, again, for many years, that is overrepresented in autopsy studies. So, people have accordingly focused on this. Of course, people with bicuspid aortic valve are often younger. That gets your attention as well. This study, I don't think it's a very good study, but it certainly attracted a lot of attention in 2002 from Italy, looking at aortic complications after bicuspid aortic valve replacement. That's replacing just the valve, not addressing the aorta. and they demonstrated a high risk of cumulative cardiac events thereafter, including 5 acute aortic syndromes, 7 sudden deaths, which could well have been dissection, etc. And 3 operations for ascending aortic aneurysm. And this has led those authors to recommend a policy of prophylactically replacing all aortas associated with bicuspid aortic valve. And I will tell you that there was a trend in the surgical community to do exactly that, or to be extraordinarily aggressive with the ascending aorta in patients with bicuspid valve. There's no doubt that the incidence of aneurysm in patients with a bicuspid valve is higher than that for thoracic, for a tri-leaflet valve, as shown here from a Mayo Clinic study. And in fact, the ascending aorta, as clinicians know, the ascending aorta associated with a bicuspid aortic valve is, even in a functionally normal valve, larger than the ascending aorta associated with a tri-leaflet valve. There was also this study demonstrating a greater incidence of reoperation among patients with a bicuspid aortic valve who have had an aortic valve replacement. A significant number go on to reoperation. Here you see of 200 patients with a bicuspid valve that were then stratified by aortic diameter. There were 44 reoperations, including 18 replacements. Note there was only 1 aortic dissection. There were 3 sudden deaths. You can't be sure what that was due to. But most of the reops were actually driven by structural valve deterioration of the bioprosthesis, not by progressive dilatation of the ascending aorta. And of course, if we've changed our threshold, if we've changed our attitude about the ascending aorta, that's going to have an impact on whether or not we intervene. But of even greater concern, here in 2007, 5 years later, a study from the International Registry of Acute Aortic Dissection demonstrated the aortic diameter of less than 5.5 centimeters. Remember, we said 6 is dangerous, broadly speaking. To give us a margin of error, it was broadly accepted that at 5.5 centimeters, to give you some safety margin, we should intervene. Remember the John Joyce study and the John Eleftheriades study, showing 6 centimeters as a hinge point. 5.5 has been pretty broadly accepted, and yet data from the IRAD demonstrate that a significant number of patients with aortic dissection have aortas less than that diameter. So using 5.5 centimeters as a threshold is not a guarantee. The 2010 guidelines from the American Heart Association, the American College of Cardiology, were written with these data in mind. And you can see here that they, broadly speaking, recommended surgery at 5.5 centimeters, as I said from the Eleftheriades data. But notice in the second part there, Marfan syndrome, vascular Ehlers-Danlos, Turner's, bicuspid aortic valve, 4 to 5 centimeters, depending on the condition, a very ambiguous comment. And this inspired a lot of surgeons to more aggressively approach the ascending aorta in the setting of a bicuspid valve and lower that threshold to 4. So many of you may have heard from your surgical colleagues that the threshold for aortic intervention in a patient with bicuspid valve should be lower. That's what this guideline suggests. What I will tell you is that the data are not there to support that. And in fact, Walter Gunteroth, when these guidelines came out, made the point that the guidelines had potential for emotional and physical harm given the large number of patients with bicuspid aortic valve. 1 to 2% of the population has a bicuspid aortic valve, and depending on where you draw the line, between 1 and 2/3 of those patients have quote-unquote significant aortic dilatation. You can keep a lot of surgeons very busy replacing a lot of aortas associated with bicuspid aortic valve. And of course, at some point, wherever that number is, whether it's at 5 or 4.5 or 5.5, at some point, the treatment is going to be worse than the disease. And that's the substance of much of the argument, is when is the treatment worse than the disease? Well, bicuspid aortic valve is not Marfan syndrome. That guideline suggested or implied that they are somehow equivalent. They are not. The outcome of patients, the natural history of patients with a bicuspid aortic valve is not the same as patients with Marfan syndrome. Now, it's true that a number of patients go on to have aortic surgery one way or the other, or have aneurysm. Notice the line here, the ascending aortic surgery is the green line. It's still relatively low for if you take all comers with a normally functioning bicuspid aortic valve. No dissections. And subsequently, the Yale database has also demonstrated that ascending aortic aneurysms in the setting of an unreplaced bicuspid aortic valve actually behave pretty well. While 13% of these patients diagnosed with a bicuspid valve had a higher rate of growth, the aorta gets larger faster, the incidence of rupture or dissection was quite low, no different than patients with a tricuspid valve. And this JAMA meta-analysis demonstrates that the combined linearized rate of ascending aortic dilatation, rupture, or death associated with a bicuspid valve is lower than that of a trileaflet valve, not greater. Our threshold for intervention on a bicuspid aortic dilatation should be more conservative, less aggressive than a trileaflet valve. That's what the data show. What about those data about autopsy studies? Well, if you look at the IRAD database and you consider the incidence of bicuspid aortic valve among patients who have dissection, whose aortas are less than the surgical threshold of 5.5 centimeters, you can see it's not a very high percentage of patients who have bicuspid valve, 2.6%. That's not far from what you would expect for the population incidence. And I can tell you as a surgeon with 30 years of experience, it happens, but it's uncommon that a patient with aortic dissection has a bicuspid valve. So I think that it has been overstated that the risk of complications with bicuspid valve are so problematic that we should be more aggressive. So I would say to Linda Pape and company, aortic diameter is not a good predictor. I agree, it is not a good predictor. The problem with their data are that number one, yes, a significant number of patients with dissection may have aortas less than 5 centimeters, but most of the population has an aortic diameter less than 5 centimeters. And the issue here is not the incidence. The issue is the risk, the percentage. Without the denominator, you can't calculate what the risk is. And the risk of dissection with a small aorta is extraordinarily low. That's where the denominator is. Furthermore, their data look like a survival curve. It's very likely that the patients with very large diameters who dissected are among those 50% of patients that we saw in the UK never made it to the hospital. So we really can't make much of those data. Now, what is the impact of the recommendations? Is Walter Gunteroff correct? Well, he is. This is from years ago when I had a patient when I was at the Mayo Clinic, still a newlywed with a 4.3 centimeter ascending aorta and a well-functioning bicuspid aortic valve. She was told that she needed to have a composite root replacement with a mechanical valve and could not have children. I think that's ridiculous. Her valve was functioning well. Her ascending aorta was not significantly dilated. 4.3 centimeters, the risk is quite low. Here's another example, a more recent one, a 46-year-old woman with a normally functioning bicuspid valve who had a 3.8 centimeter aorta. It was recommended by a surgeon at her site to have a root replacement with a mechanical valve, taking a normally functioning bicuspid valve and subjecting that patient to the risks associated with a mechanical valve. Furthermore, there are risks associated with the operation. There's no operations free. This is a random email that was sent to me by a plaintiff's attorney who was looking for someone to support a lawsuit around a 59-year-old with a normally functioning bicuspid valve and 52 millimeter aorta who had a catastrophe in the operating room. Does it happen often? No, but it does. So what to do? Let's finish up with some what to do's. Well, the risk factors we know associated with rupture or dissection include not only aortic enlargement, but also some genetic conditions, hypertension, and smoking. Our data from Mayo demonstrated that actually the risk of aortic events, the hazard ratio associated with a smoking history was equivalent to that of the hazard risk associated with an enlarged ascending aorta. So I think that we should practice evidence-based care. We should individualize that care. The guidelines are a beginning of the discussion, not the end of the discussion, and they should be nuanced with patient-specific factors. And one of the challenges with our guidelines is they do not have enough patient-specific factors. So for example, we've looked at our data at Mass General and identified while age is a factor and diameter is a factor and surgical risk is a factor, we really need to think about this in a multi-dimensional way. The risk of a 5 centimeter aorta in an 80-year-old is not the same as the risk associated with a 5 centimeter aorta in a 40-year-old. The risk of dissection and the operative risks are different in those individuals. We need to nuance our recommendations based on age, on smoking, on presence of hypertension, on presence of connective tissue disorders, et cetera. Remember, when you have that discussion with the patient, they're going to have biases that impact their judgment as well, looking at short-term gains, long-term gains, the endowment effect, et cetera. I'm very interested in all this prospect theory stuff. That impacts the discussion that you have with the patient and the decision that the patient makes. Oftentimes they're worried about having a sword of Damocles hanging over their head. They're afraid that they have a time bomb in their chest. They'd rather take a certain risk of an operation tomorrow than live with the risk of a procedure. And of course, it's always different for us. The patient is the one who takes the risks, not the physician. It's always safer for us to recommend an operation. So perhaps not surprisingly, physicians, be they surgeons or cardiologists, tend to be more aggressive about recommending an operation. We're not at risk of death, and we don't suffer the morbidity associated with the operation. But if the patient dissects and we have not recommended an operation, we're at risk of being wrong and, frankly, probably at risk of being sued. So how do I make recommendations? If there's a well-functioning valve, if they're higher risk, if they're older age, I tend to be less aggressive about recommending an operation. A 5 centimeter aorta in an 80-year-old, I wouldn't touch it in most instances. A 5 centimeter aorta in a 20-year-old is a whole different story. Nuance it with hypertension, tobacco use, their operative risk, patient anxiety, lifestyle limitations. If you see a patient in the office and they've been told they can't lift anything more than 10 pounds and they're a bricklayer, then you're going to have to operate on them. I've had airline pilots that I've had to operate on because they cannot continue to practice their profession unless they have surgery. But I do still think that there's a place for surgical humility. John Hunter, the father of scientific surgery, said no surgeon should approach the victim of his operations without a sacred dread and reluctance. I think that we should be honest about that. There's no such thing as a free lunch. There is no operation that is zero risk. So I will close with the 2022 guidelines, just so you know how they're framed. Again, I think guidelines are the beginning of the discussion, not the end. Notice there are very few comments here about mitigating factors. There's a little bit about other surgery. There's some comments about additional risk factors for aortic dissection, but it needs to be nuanced much more than it is right now. But if you want a take-home, it remains that a class 1 indication is 5.5 centimeters, and this is for bicuspid aortic valve, or 10 centimeters squared per 10 centimeters per meter squared. I apologize for that typo. 5 to 5.4 centimeters with these risk factors. I don't really have a problem with somebody intervening on an aorta that's greater than 5 centimeters. 4.5 centimeters if they're having other surgery. The 5 to 5.5 with a quote-unquote experienced team. What surgeon have you ever heard tell you that they didn't have an experienced team and that they could do the operation at low risk? So I think that we're fooling ourselves when we think that there's zero risk. But this is what the guidelines are now for ascending aorta with a bicuspid valve, and I think that we should be less aggressive particularly if someone's aorta is less than 5 centimeters and they have a well-functioning bicuspid valve. I am very reluctant to intervene. So with that, I thank you. I believe I've run a few minutes over time, and I apologize for that. Thank you very much.